A very warm good afternoon to one and all. Before we proceed with today's scheduled lecture, let's just keep in mind the famous quote put forth by Thomas Edison, which goes like this: Our greatest weakness lies in giving up. The most certain way to succeed is always to try just one more time. Let's move on to today's session on residual ridge resorption. Residual ridge resorption, most popularly denoted as RRR, is one of the main causes of loss of complete denture stability and denture retention. Extreme resorption of maxillary and mandibular ridges will lead to sunken appearance of cheeks, unstable dentures associated with pain and discomfort. Residual ridge resorption hence poses a clinical challenge towards successful fabrication of a complete denture prosthesis. Before we move further into the lecture, let's just take a look at few terminologies. These are residual bone, residual ridge, and residual ridge resorption. Let's see what a residual bone is. It is that component of maxillary or mandibular bone that remains after the teeth are lost. Residual ridge, meanwhile, it forms after the extraction of teeth and it's characterized by a loss of mucosa when compared with the dentulous ridge. Combining these two terminologies, residual ridge resorption is defined as the diminishing quantity and quality of residual ridge after the teeth are extracted. I hope these three terminologies are not confusing for all of you. Moving further, let's see what exactly residual ridge resorption is. It is a chronic, progressive, and irreversible process, with the rate being the fastest in the first 6 months after extraction. The bone resorption activity of the residual ridge continues throughout life at a slower rate, resulting in removal of a large amount of bone structure. This unique phenomenon has been described as residual ridge resorption. Now let's just take a brief look into the pathology of this process. Post-tooth extraction, a cascade of inflammatory reactions is immediately activated, and the extraction socket is temporarily sealed by blood clotting. Epithelial tissues begins its proliferation and migration within the first week, and the lost tissue integrity is quickly restored. Histological evidence of active bone formation in the bottom of the socket is seen as early as 2 weeks after extraction, and the socket is progressively filled with newly formed bone in about a span of 6 months' time. The most striking feature of the extraction wound healing is that even after the healing of wounds, the residual ridge alveolar bone undergoes a lifeline catabolic remodeling process. Let's just take a brief look into the classification of residual ridge resorption. The most frequent term that the patients say is that my gums have shrunk. Actually, the basic change in residual ridge resorption is a decrease in the size of the bony ridge under the mucoperiosteum. It is primarily a localization of bony structure. Sometimes it may leave the overlying mucoperiosteum excessive and flabby. Now, there exists a wide variety of shapes and sizes of residual ridges. They're categorized into common residual ridge configuration in a system of 6 orders. This was put forth by Atwood, and he has classified residual ridge resorption into 6 orders, order 1 to 6. Order 1, pre-extraction. Order 2, post-extraction. Order 3, high well-rounded. Order 4, knife edge. Order 5, low well-rounded. And order 6, depressed. Let me repeat for all of you. We have pre-extraction, post-extraction, high well-rounded, knife edge, low well-rounded, and depressed. Now just take a brief look into the pathogenesis of residual ridge resorption. Immediately following the extraction, which is order 2. Remember, order 1 was pre-extraction, order 2 was post-extraction. So as soon as you follow the extraction, any sharp edges remaining are rounded off by external osteoclastic resorption, leaving a high, well-rounded residual ridge, as you can appreciate in order 3. As the resorption continues from the labial and the lingual aspects, the ridge becomes increasingly narrow, ultimately becoming knife edge, as visible in order 4. After order 4, as the process continues, the knife edge becomes shorter and even eventually disappears, leaving a low, well-rounded or a flat ridge, as you can see in order 5. Eventually, this also resorbs, leaving a depressed ridge as appreciated in order 6. You can conclude that residual ridge resorption is a chronic, progressive, irreversible, and cumulative process. Bone resorption is a process by which the osteoclasts break down the tissue in bones and release the minerals, resulting in the transfer of calcium ions from bone tissue to the blood. These osteoclasts, as you can see in the diagram, are multinucleated cells that contains numerous mitochondria and lysosomes, and it is generally present on the outer layer of the bone just beneath the periosteum. The hallmark of the resorbing surface is the appearance of scalloped erosion called Hauschup's lacuna or resorption lacuna. Attachment of these osteoclasts to the osteon begins the process. The osteoclast then induces an enfolding of its cell membrane and secretes collagenase and other enzymes important in the resorption process. In the due process, high levels of calcium, magnesium, phosphate, and other products of collagen will be released into the extracellular fluid as the osteoclast tunnels into the mineralized bone. This resorption phase lasts for about 8 to 10 days, presumably the lifespan of the osteoclast. After completion of one resorption lacuna, the osteoclast can move along the bone surface and restart the resorption process, or may also undergo what is known as apoptosis, which is programmed cell death. Now let's take a look into the direction of residual ridge resorption. The maxillary ridge resorbs in an upward and inward direction to become progressively smaller because of the direction and the inclination of the roots of the teeth and the alveolar process. As opposed to this, the mandible, which inclines outward and it becomes progressively wider. Now, this opposing change of maxilla and mandible will lead to the patients appearing prognathic. Hence, you can conclude that residual ridge resorption is centripetal in maxilla and centrifugal in mandible. Let me reinforce this again. A maxillary ridge resorbs upwards and inwards and hence becomes more smaller, which is why we call the direction of the resorption is centripetal in maxilla, and in mandible, the resorption is inclined outward and the mandible appears to be wider. Hence, which is why we say the resorption in mandible is centrifugal. Now let's take a look at the pattern of residual ridge resorption. The patterns of bone resorption in the mandible. A large proportion of the bone loss occurs in the labial side of the anterior residual ridge. It happens equally on the buccal and the lingual sides in premolar region and lingually in the posterior or the molar region. Okay, please bear in mind, in a mandibular residual ridge, the resorption occurs mostly in the labial side of the anterior ridge, equally on the buccal and lingual side in premolar region, and lingually in the posterior or the molar region. Whereas in maxilla, the bone loss primarily occurs on the labial or the buccal aspect. Therefore, while we do teeth arrangement, we should try and restore the natural position of the teeth before they were lost. Hence, always when you do a teeth arrangement, the maxillary teeth are arranged slightly labially and buccally, whereas in mandible. The teeth in the anterior region are placed labially on the center of the ridge in the premolar region and slightly lingually in the molar region. I hope the concept is clear for all of you. Please bear in mind, the resorption is not the same in the anterior, the premolar, and the molar region. It is very slightly different, which is why we follow a different teeth arrangement while we arrange the mandibular teeth. This begins us to the end of today's session on residual ridge resorption. The coming sessions will continue with the consequences and the prosthodontic management of residual ridge resorption. Thank you so much for all of your patient listening.